All right, this would be part 2. KT taping, part 2. Technically, KT tape, I believe, is branded. So you can use, I know you can safely use the term kinesiology taping. So anybody can say they do kinesiology taping, therapeutic taping, but that's, I think more people know what kinesiology taping is, and if you plug that into a search engine, you know, KT as the brand just has the most resources. So if you're gonna look up images and videos, look up KT taping for whatever it is. Video might not be able to look this up, but if you look up through any images, KT taping or kinesiology taping for bruises, I mean, it's pretty cool. And it just shows that predominantly where the skin, where the tape was, the superficial fluid that was underneath that tape got moved. So it's a case where it's pretty legit in showing. Now, my only thing with this is when you look this up, people can make the lattice work and stuff very complex. They can make it incredibly beautiful. I'm a bigger fan of make it a bit more simple and approachable, right? So as opposed to teaching a lot of the varied shapes, or even like I learned how to like cut, and not like learning a big thing, but cutting holes for fingers and slotting them over like a glove for the hand. The problem with that is it just wasn't very practical. I go wash my hands once and that's rolling out. So there's some areas of the body that just are harder to tape, and like taping around and in between fingers, I would just go, there's gotta be something else we can do. Is there a therapy glove or something out there that you could use? Like, I don't know, but I think the tape isn't gonna be the best thing for that. When we get to the feet, that's one where I've tried to create a hack here in the form. It's hard to show because I don't have a picture of the bottom of the foot. But what is supposed to be happening is like the green piece of tape right here is being hooked and pulled over so that the bottom part is holding down the other tape ends. Because that was the big issue at the bottoms of the feet, is that's where it would love to roll up, especially if a person's taking on and off, putting on and taking off socks, right? So, anyway, to the rules. The main rules that we have to do in order to do this correctly. You can do it incorrectly and you're gonna see what happens, but if anybody has, oh, here's a piece of, I'll have to pass this around once I cut it up. Yeah, this is some of the Sport brand of the KT tape. Has kind of a sheen to it. And then this is the Spartan tape, which has been pre-cut, not too beautifully. If you are doing that, I'll demo a lot of this, but it's just like, put the anchors over top of themselves so when you cut, you get both done at once. But let's start with, let's see what I have. Yeah. Start with these. So this, if you are having to do this all by yourself, you have the pre-cuts. So everybody get at least one pre-cut ripped off and in their hand. Don't take the backing off, just have it like this. Keep the backing on for me. If I was pre-cutting this, then I would cut off my strip. What's nice is they usually have a grid pattern in the back so you can kind of measure and approximate, getting a sense of how much tape to use in each body area. There's a point at which like you kind of get a sense of it, but as you do this, you get a better sense of how much stretch you get. The more you do it, you'll be able to guesstimate really well. Guesstimate, solid term. So, okay, if I turn this over, I can get a pretty decent cut. I've tried to be more sparing and not just cut the corners, but I found that it just gets easier to make the full U shape. So if I go here, uh-oh, isn't it that good? Here we go. You make a small mess, but then voila, I have my rounded corners. So that's what that would look like. Nothing too brutal. But here's the important part. Pre-tear anchors. Anchors are going to be the ends. the starting point and the ending point. So we're gonna get, usually in this case, this is cut where we have about a whole square here. You usually want about at least an inch for the overall length of an anchor. A bigger anchor is better. This is the part that is gonna hold the tape down and not roll it. But look, like how amazing this is. I pre-tear that, so I have a flap, but I haven't taken the backing off. I spent about $3 grand learning how to do that. Here we go. Here we go. Now, if you get certified, then you can actually go and start like getting into that circle and start teaching that kind of stuff. So it's a cool pathway. So I don't discount going through the full workshop series. If you really want to be able to point at, I'm really good at this, then you should go take the KT taping seminars. They give you these giant tome manuals of how to tape every single body area. There's some philosophies I'll say the new science has shown maybe not true, because all the stuff I was talking about related to sensory input and what that does to the nervous system, the one thing I disagree with is that if we tape in a particular direction, that will turn on a muscle or turn off a muscle. That's probably not what's happening. So what we have now is these pre-torn anchors, and that just tends to be the term people use for these ends. We don't want these ends to have any tension on them. If we have the whole tape on tension, that's more likely to roll up. So the ends, the anchors, are applied at 0% always. And then this is the working part of the tape, the part of the tape that we actually stretch, and we'll go over the area we're trying to affect. If it's a pain spot, we want to make sure, like in this case, the middle of the tape is where the recoil is going to occur, and we're going to get a lifting effect there. I'll bring out some paper towel to kind of more clearly demonstrate that. But this, ideally is what's happening, and it's lifting the skin with it, right? So the center point of the stretch part of tape is where the most force is occurring. So wherever the ouchie is, you want that if you're talking about decompressing a particular area. Crossing joint lines, it's a case where the anchor has to be pretty far out so that the stretchy part of the tape is crossing the joint. So the stretched part of tape has to be going where you want it to be doing something. So I call it the working part of the tape. This is where the work gets done. So now, part of this, and you can apply this in pieces, like I could pre-tear right down the middle. This makes it to where I can apply each segment of this at a time, rather than taking all of the backing off and then trying to apply it. The tape sticks to itself and goes this way and that, and it gets messy. So pre-tearing segments like this just make it much cleaner and easier for you. So if I'm applying this on myself, and you can try, if you fail, that's totally okay. I am going to take off the backing of an anchor. I'm just going to take off one piece at a time, so you can join along with me. And I'm going to do we're going to tape for carpal tunnel. There's more we could do here, but at the very least we could start here. I want this tape to go right on in the middle of my palm. Why? Because I want the stretchy part to cross the wrist, cross the joint line of the wrist. So I get the anchor on, no tension, just stuck. Now, and you're doing this one-handed, so it proves that you can pull it off, right? Now I can take off the backing of half of the stretchy part of the tape, if I can get a hold of it. Come here, you. Now I can use the backing as a handle. So I can grab any part of this backing. In this case, I can hold this down. When we're doing it on a person, I have one hand to hold the anchor down. But now I stretch it, and stretch as much as you feel like. Now here's the thing, and with mine, I have these waves, but I can look at it and go, there's 100% tension, there's 0%, somewhere in between, 50%, start around 50%, and just stick it down. Now, oh, sorry, tissue elongated. So how do I need my wrist? Do I want it like this?
No.
Do I want it like this or like this?
Like this.
Like this. Lengthen the tissue, elongate the tissue. And then here we go. Stick it down. Get that part secure. Now we can go to the next part. How much of my forearm can I get? Now I'm to the anchor. What do I have to do now? No tension on that anchor. So I have just this segment left. I pull that off. You can do it real fancy. You just use the backing and go whoop.
Did you stretch the second part here?
Yes,
a little bit more?
yeah,
Okay.
yeah. Stretch any part as long as the anchors. The anchors are the only 0% tension. Mm-hmm. Then, if you want it to stay stuck, but if you don't want it to stay stuck, then you give it you just go along the edges and rub and get it applied. And what does it feel like? Does it feel like a miracle? It's a miracle.
I feel like it's better, man.
Yeah.
It's cool to see that. You'll see your skin kind of fold up and wrinkle from the tape pulling it.
We'll call it keloiding. But that is, if you leave this on a long time, you'll see the tape kind of start to get more ripply. And it means it's having that effect on the skin and superficial fascia. So good point, Sarah. So first part is just to feel it. You gotta, if you haven't felt this on your body yet, then there. And it has a sensation. It feels like I have tape on the anterior portion of my forearm. Now we could do more stuff. If we had a wrist issue, I tend to think like plus signs. You know, we could go right across the carpal tunnel. That's a hard canal to get tension on. So my easiest go-to is, oh yeah, trash can, makes a lot of sense, would be with nearly all wrist dysfunction, I would tape both sides and see what happens. We could do smaller segments and maybe tape just for the thumb, just tape for like the medial portion of the wrist, the lateral portion of the wrist. But you know, you could cut this in half and do a little piece. But even a small piece of tape, it's an anchor, a stretch part, and an anchor.
Would you want to split the anchor, like on each side of the thumb?
You'll see people do that to get it to maybe secure in such a way. I did not tend to do as much of the split anchors. I'll demo that with Deb with the shoulder thing, because you can kind of try to trace the anatomy. So I put quite a bit of tension on mine, so I do feel a sense of it tugging. This thing, we have an elastic thing here, right, like a rubber band. It has been stretched when it was applied. It wants to, the physics of it, it wants to go back to its normal resting length. So I do have a sense of my wrist wanting to be pulled into flexion, right? Now I can balance that out over here, but that's where, sure, you know, enough elastic tape crossing a joint line is going to have an effect of kind of pulling stuff in a particular direction. I like the Spider-Man reference. So this is just, you know, that's the beginning. The difficult part is just figuring out how to apply these strips of tape and not have it fold over and stick to itself and become a mess. So tends to be just getting really conditioned and good at pre-tearing your anchors and maybe even tearing the stretch part into multiple segments and applying it bit by bit so that you can do it without it being a mess. Now, the amount of tension that we should apply on each area, that's listed here pretty good. Again, the anchors are always at 0%. For other effects, if we're talking fluid movement, I'm going to really simplify it. For fluid movement, we want it to be less than 50%. When I show you how I apply it, sometimes I'll just kind of oscillate my tension so that some areas of the tape are more at like 25%, some areas of the tape are closer to 50%. But I'm not a fan of, especially as you're just learning this, with somebody saying, I want you to apply that tape at 37.2% tension. And the manuals did tend to get a bit more precise like that. They'd kind of be like 20 percentiles, 30-ish, 35 percentiles. I'm like, once you're kind of like, it's either a lot a bit, a halfway a bit, or less a bit, you know?
And what it feels like to the patient.
Yes. So, for fluid stuff, for fluid movement and connective tissue related stuff, fluid movement should be probably less than 50%. Fascia, connective tissue stuff, try to get right to 50%. Kind of that happy middle ground of it's pulling on the skin, but it's allowing for there to be a tug and a pull in both directions. Like it's not limiting the amount of elasticity on the skin. The more tension you put on the tape, the more it's going to be like kind of pulling and or even pushing down into the skin. It'll have a perception of more stability. So more tension is usually used when crossing a joint line. So if you're doing joints, if you're doing a joint anything, joints, posture, but let's just say joints. If we're crossing joints, then we want plus 50%. And then but then be creative. There were some areas that I learned, like with trying to get the shoulders back. Now, I'm sure someone out there can disagree with me in the internet sphere. And I'm not really on any kind of pedestal about this, but it's just a case where through some trial and error, if I had one area where I went 100%, it was across the front of the chest here, to try to help a person get a sensation of feeling pulled back into better shoulder alignment. And I had a client that got this done every week for at least 3 years. Where it was really, that's that bad shoulder arthritis person, the one that I talked about, really bad arthritis, couldn't touch it. I shook the daylights out of it, and it finally calmed down enough to finally get massaged. And then we would throw in the KT tape. And that was a management strategy for this person, even though this is bad osteoarthritis with very limited range of motion, but we got the symptoms down to totally manageable levels if she just came in every week to every other week. And this ended up being something that was just really helpful to her. But I didn't make any promises. It was, let's give this a shot. Money-wise, you can charge per strip. You could charge, you need to do the math based on what you buy. How much is it per piece of tape? I think it's in like the dime-ish to a quarter kind of world. I think 20-ish cents. Yeah, I think call it closer to a quarter. I'll have to bring up some metrics if somebody wants to do the math on one of the bigger rolls. But not that much. It's something that you could just include. I'm a fan of giving people an experience to see if they like it. And then moving forward, the proof's in the pudding. You did a nice thing for them. If I'm thinking from a customer service side, related to those that are about to graduate, it's like little soft touches like this that maybe, especially as you're just trying to kind of figure your way through helping people, like starting with a nice general full body massage, and then maybe including something like this. You know, there's a bit of a, I care about you. I put a Band-Aid on the boo-boo. And it's something that's there. They take it with them. That first option of maybe offering it as a gift, and then when they return, you can be like, if that worked for you, $10. Something like that. You know, I ended up typically including it. One of my strategies, I think I've mentioned with the longer sessions, 90-minute sessions, I just be like, this is the package price, includes this and aromatherapy if you want it. If you don't, same price. And it just made my life easier. And I would use it when I needed to, and I would tend to just find a way. And it kept me in practice, and it's good. How do you go wrong? If they like it.
How much is bugs in Amazon?
Those, I think, 16 or $17. Think 20. Think $20 for that. But you can get the big rolls of even pre-cut. You can get like 120 feet. And they're pre-cut like that, and then it goes down in price. If you buy a big roll, then you'd be probably paying for that amount of tape closer to $10 to $12. So, but yeah. How much you buy, break down the feet. Usually one pre-cut strip is about a foot. So 1 foot for for this. Now, as you stretch it, it makes up for more distance. So when you see 120 feet, you have 120 pieces. If that cost $60, yeah, somebody do the math, but there you go. So, all right, now the next part I'm gonna do is just point out some aspects on this model of areas that I have found more difficult and or more easy. And then we should just probably go right into me demoing on an actual human. So with this thing, come over here, buddy. Walk it. Okay. So a more complex one is this. Why? Because each area I'm taping on, I had to put that skin on tension. So what's great about the massage table and massage positioning is inside lying, this shoulder's up. So I have a person roll their shoulder back. How do I order this? All right, it was this one. So this would be, take the pillow out, so they're tilted like this, reach for their feet a little bit. Now this is all on tension. Great. Same thing for this one. This one's gonna go straight down on top. This one should be a little bit further over. In your charts is a bunch of cool anatomy terms I used related to bony landmarks and muscles and stuff. The idea being of like what we're trying to cross here. If I'm thinking about the function of this, and this is my version, and we'll come up with a simplified way to get this big one. But the goal here, for example, if I'm trying to be real fancy, I'm just thinking about all the cool stuff I can possibly think about related to the anatomy here. So I'm going, what's the movement people tend to have the most problems with when they have shoulder dysfunction? Abduction. They have the hardest time with abduction, and then anything typically past 90 degrees. Now, in order to get past 90 degrees, your clavicle and your scapula have to move. So the acromioclavicular joint, where your clavicle meets your scapula right here, that has to pivot and move a little bit to allow you to get past 90 degrees. More so in abduction, the sternoclavicular joint here has to pivot more when you go past 90 in flexion. But this is the one that is far more common that you'll see limited. People will come in and go, owie. This is the one. So what I'm trying to be here is a helper to the shoulder AB ductors. And what those are medial or intermedial deltoid, because you have anterior deltoid, posterior deltoid, and this medial deltoid. That's supposed to be the boss AB ductors. Remember, deltoid, if we're comparing our shoulder to our hip, deltoid is like your glutes. There's 3 sections of deltoid. You have 3 glutes. They hug the ball and socket joint. They're supposed to be the boss of the ball and socket joint, deltoid. So I want my anchor to go past the deltoid attachment, which is lower down than you think. It's a bigger muscle than you think. If I had Schwarzenegger deltoid, then I could, present, but it's lower down. So that's why this one's so far down, is I want this to be helping out deltoid. Then there's upper trap, and even deeper to the rotator cuff, supraspinatus. And I'm just thinking about those three and trying to make this tape cover all of that. So through palpation, it helps you. You're like, oh yeah, deltoid. And if you feel your shoulder and you start working your way down and kind of go into abduction, muscle testing, you should feel something kick on every time you abduct. Keep going lower until you stop feeling it. Well, you might be feeling some triceps at one point, but mine ends about here. It's lower down than you think. So big muscle, even if it's not big. And then trying the struggle I'll have in this body area. Let me take his medals away. Oh no. Got caught doping on the Olympics. So, I would like to tape as far up onto the neck as I can, but this person has a lot of, it's like me when I don't get my hair cut. Starts just keeps going. So I have to manage how far I go up on the neck. And that's my only limitation there, okay? This next one, the one that goes straight down and across here, this one should be over here. That is supposed to act as a stabilizer for the AC joint. So when we're looking at this, I tried to think what I thought was the best order. There is not an incorrect order. You can do it in any order, it's fine. I was trying to think that when these overlap, see how this one's holding this anchor down and how over here, holding that anchor down. So I was just thinking, when there's overlap, when is it more okay? We don't want the anchors to not be on the skin, but it's okay if other parts of tape go over top of anchors. So I just wanted this one down first, and I wanted to do this one, the big long one, last. So this one, same thing, I just need the arm down like this, and then going across the AC joint, because then I'm thinking, related to all this stuff, hey, that's a really important joint. When people don't move their shoulders a lot, this tends to get like a rusty hinge and get stuck, kind of jammed. There's a lot of things out there, and if I haven't shown you yet, I will. Maybe we'll do a little bit of that today, of how to free up that AC joint. This one, you gotta be more careful of, but here, you can affect this one, and you can find it quite easily. So helping, it's not about getting it to click. It's about that analogy I use with WD-40 on a rusty hinge of a door. It's about kind of creating some pressure and gapping the joint just a bit and having a person move that joint back and forth thinking, come on, Tin Man, go, be less creaky. So that's there, trying to be the AC joint helper, okay? The next one, and this is a bigger piece of tape than you maybe actually need. Now, what I really want to highlight is for this one, and especially the big long knee ones. When you see something that has a big long swoop or arc to it, a U shape, and kind of big bend, my suggestion is to take this and cut it in half and do 2 pieces of tape instead of 1. So that you can concentrate just on this anterior portion, anchor it down over here, and then do another one creating kind of a V shape here, and then do this back one. It's much easier. I know I did this one a lot, but this, you can see it actually here. It's trying to roll up. So it rolls up less if you don't have the whole piece of tape bending like that. So instead of a U, make a V. And really the V is going to turn into an offset X, because you want the anchor and anchor. That would be the best one. And that will be the one I demonstrate, is taking this long bend and turning it into an X. The goal...
The tape is actually intersecting at 3 points. It's at 3 points.
Yeah.
Okay.
Ideally here, like if I start thinking a lot, it's like pec major crossing over pec minor. Deltoid attachments and coracobrachialis are getting affected in here. In her situation, when I tape for her shoulder, I may do something that goes directly more over top of the shoulder flexor groups. But now, so this is more about saying to the pecs, hey, be longer. Then this swoop, the hard part with this one that was always more annoying is bringing this down low enough to actually be down here without it going across like an armpit crease. You're taping here and then you're trying to, and like you got a gap or a crease of skin here and a gap and a crease of skin back here. And that was just an annoying place to tape. That's why this one just ends up being one of the most advanced ones to learn, just because it's a lot of moving parts, literally. So if we taped across from the pecs and then just cross over deltoid and anchor, I'm going to anchor on the triceps, but we're not really thinking about triceps. Then we're going to flip it over. We put an anchor on the biceps, cross deltoid again, and then here we could just tape almost anywhere, but if I want to be really profound, then I could make sure, like I palpate, I find the spine of the scapula. Superior to the spine, above it is going to be supraspinatus, so superior to the spine, supraspinatus, infraspinatus. So here's the spine of my scapula, above it, below it. Supraspinatus is a rotator cuff muscle. It's about abduction and holding your shoulder just up. Infraspinatus is about external rotation. It's the one that tends to get really weak on people because we get stuck like this. Not to point you out too much, but literally the body, if you want to just clean cut what the body tends to do to your shoulder when it's hurt, puts you in a sling. So that's internal rotation, flexion, adduction. And then usually the challenge then is to lengthen all of those and get you back here. So this piece of tape can be coming across and be trying to like go across infraspinatus. And if I wanted to go even further, you know, this is a little bit too far, but I could have this bent down and try to actually have it affecting either, in this case, it could be rhomboids, which is a scapular retractor, or I could have it bend down and have it attach on lower trapezius, which is a scapular depressor. Now, that's a lot of words for movements and stuff, but the idea is that we want to take a person from shoulders stuck in elevation and protracted. I want to take them to retraction and depressed. It's good depression. So when I tape them, I have to, person's laying on sideline, pillow out, they're stretched like this, I get this piece of tape on, I get this piece of tape on, then I have to have them roll back like this, get the front piece of tape on, and I have to have them roll forward, and I get the back piece of tape on. It's not awful, it's just you have to do that 10 to 20 times until it starts feeling like it makes sense. So that's an example and an explanation for just the philosophy. Now, I've seen people just do the AC joint one. And if that works and it feels like the rest of it's just busy and doesn't do anything, sure, you can do just one or two. It's totally fine. You could keep applying tape until you've created a really amazing, modern art piece. Same thing here with the knee. Just to explain through the anatomy, and then we're going right to practice. Hold your shorts up. Here, the most common place for a tendonitis to occur is just superior to the tibial tuberosity. So you have to remember the kneecap, the patella. Above it is a tendon that attaches to all your quadricep muscles. So all your quadriceps come together, become the patellar tendon, which attaches to your kneecap, which is why you can make that, bounce up and down when you fire your quads, right? Below it is actually technically, you'll hear most people call it a tendon, but if I want to get real, smarty pantsy, it's a ligament because it's bone to bone. So this goes from your patella to your tibia, tibial tuberosity. And right there is where the most common, by far, that's where when people get patellar tendonitis, that's where the symptoms will tend to be, is inferior to the patella. maybe a little bit lateral and medial. The thing I'm gonna say about this though is unless you really, really, really feel confident in what you're doing, and I would just tell you not to be too brave at all, don't be taping too close to the patella. Don't be taping on top of the patella. Leave the kneecap alone. Just leave it alone. It floats around in there. You don't want to get it pressed down into the sulcus where it's rubbing more than it should be. Like, I mean, this is one where if it's offset, suggest going to the physical therapist and have them get a good read on it. If you're working in a medical team setting, then maybe then you can work with the athletic trainer, work with the physical therapist, and they show you what the goal is, and maybe you can get, maybe they'll defer to you to do the taping, but make them do the assessment related to that, okay? You can still help a lot of the common symptoms here. I'm just saying don't try to track, it's called like trying to get the kneecap to track more effectively. Just please leave that alone. You can affect all this stuff though. So if I find the tibial tuberosity, which I can feel right here on myself, I find my kneecap, there's a weird springy cord thing right there, and then I go until I feel bone again. And that's the tibial tuberosity. This piece of tape is supposed to go right across that. The other pieces of tape are meant to ideally go more on the lateral collateral ligament and the medial collateral ligament and come all the way up. And this is too low. This should be up here. The X should be further up, okay? Because I want that to be at where the patellar tendon starts, where the quadriceps just end. So I don't want the X to be right here, just above the kneecap. I want it to be where the tendon just starts, way up here. That meaning I would affect the part of the tendon here without worrying that I'm too close to the kneecap. And then I can affect the ligaments on either side of the knee. These are very superficial. And lateral LCL, MCL, lateral collateral ligament, medial collateral ligament, those are common areas that have dysfunction. People can get a tendinitis here on the medial side of their knee. That's where your sartorius and your gracilis and your hamstrings attach right there. So sometimes people will get a medial knee something. And the idea here is it covers all of it. It covers stuff related to a tendinitis, which really would be a ligamentitis. But it's ouchy down here. Okay, tape goes across it. Potential ouchy on either side goes across those. Whether it be ligament or it be tendon, we're covering all of our bases with a formula like that. So I'm like, and it's also integrated. We're learning about how complex the body is. For every agonist, there's an antagonist, and all the synergists. So I just go, why wouldn't I do both? If I'm trying to save that quarter, you know. But for the efficacy and for giving you a pattern to follow that's going to give you your best results, this is a case where I say just do both sides. And that's why this is how it is, and you'll see it listed in the form. All those anatomy pieces are talking about the tibial tuberosity, LCL, MCL, and the pezanserine. Pezanserine is the name for that common tendon point I talked about right here. So that's what that's talking about. I mentioned the stuff with the elbow. Same philosophy, but that one's way easier. The knee though, where it bends right here on either side, it loves to pull up. And the knee's tough because since we're working on the sides of the knee, how do I put their knee when I'm applying it? I always have them flexed like this, trying to keep this long, but it's very difficult to get these to stick without these sides rolling up. So same thing, why not do an X and an X and a bracket? So take the long swoops, make them 2, and you're good. And those are really the only 2 areas I wanted to really highlight, is make this one 2 pieces, make this one 2 pieces, make this one 2 pieces. And that'll be when I actually do the demonstrations. That's what I'll be doing. This, as I said, I had to do because I only had $3. So, voila. Any fancy questions? as I turn him around and talk about areas I think is more difficult. The back, especially the low back, there are some people where it can feel like it has an effect, okay? Getting this one and or this one, where it's the two up and down, the paraspinals and one across. Now you could just do the ones up and down, right? The challenge here is positioning a person where you can put this on length. One way is we learned it in the clinical setting was just to have a person like reach for their toes. They're just like, whoop, and you come around behind them and, you know, that's interesting, right? So the easier way I have on the table is actually to get the bigger pillow, have them lay on their tummy like that. It's a little bit tougher to, it's hard to sometimes get it symmetrical. I've tried really hard. This one, trying to go for the real low back stuff, especially SI joint, it's difficult because ultimately if I was trying to do it in a way that affects the anatomy the best, I got to get those anchors on their glutes. So now I'm having to maybe move underwear and stuff like that. So it's just a more nuanced thing of if you're concerned about secondary touch and application, save this for clients that you have some like foundation with. Not first time clients because it's just, you know, some tape on your upper glutes. And the thing is this is where out here we have, you know, fluffier tissue, where all do. So it's just, I have a struggle with saying, although sometimes the sensation of this across the lumbar dorsal fascia can have a sensation, taping for the spine hasn't been one that I've seen nearly as many good results comparing it to things like the shoulder. So up and down the ribs, not as much of a thing because you don't move your thoracic spine in the same way. So really there you just have to get the arms on the sides of the table or reach forward, and then you can tape here. Okay, but the low back area, it's worth giving a shot and seeing how you feel, but I'm just saying that there's complications from, you could do the up and down, you could do the up and down and split over, up and down, split over. The idea being I'm helping facilitate glutes functioning in relation to the low back, but yeah, just it's tape on the upper glutes, and if there's any body hair here, then you got that as a thing too. So, it's one that I didn't do as often for a few reasons, right? This is a perfect area for cupping. So, all right. I think that will end that first part, and then we will recongregate. We'll take a nice break, recongregate over in the other classroom, and then I'll start out with Deb, see what we can, I'll start out with just making something up based on what's going on. Because in the end, if we can have a sense as you get through to the point where you're doing better and better assessment of what's going on, you can think about individual muscles. So if it is a shoulder flexor, where are those tendons? They're somewhere here. If it's a shoulder abductor, and then we're talking deltoid and stuff, but shoulder flexors, that may be one where I try to think about that anatomy. And we'll just look at a picture of like bicep brachii and coracobrachialis, and you go to your anatomy charts and you try to just tape over the anatomy. And you're thinking, I want to make this tape help out bicep brachii. I want this tape to help out coracobrachialis.
Like a motivating thought for me is the more direct you are in the more bang you get for the energy you put in. The more bang you get for your buck.
Right.
More bang for your buck.
Yes.
Your energy is used more efficiently. 15 minutes is going to feel just as effective as a 60-minute if you're hitting the right spots.
You're saying that, yeah, once you have the tape on this, you'll feel like you're getting more efficient movement, right?
Sorry, I was backing up to the analysis. Getting better at I was thinking about analysis as in like a pre-assessment,
Oh, yeah.
not as much of
Yeah.
chart. Sorry, I was
Yeah.
on a different track.
No, you're good.
But that was still the thought.
I really do say, in general, follow your intuition. Because in the end, worst case you discover is the way you taped it that time wasn't as effective. So change it up. Tweak it a little bit. And then work your way to what ends up feeling like it's encouraging and causing the best effect. Because in the end, you just don't want to cause harm. The nice thing here is it doesn't, it's very, very safe as long as it doesn't irritate the skin. And you don't tape, their eye or their mouth closed. Which some clients you might want to, but don't do that. Make sure you don't tape the skin over top of itself. So if it's, that'll be one thing that is a challenge. If the skin is loose and or, that's a thing where sometimes you gotta kind of like pull and tug it in a particular direction to kind of hold the skin in tension as you're applying the tape. I've worked with people that, for a variety of reasons, I got very loose skin. So it's a case where like I'm a perfect example of that tendency. But even with frailer people, that's the only thing sometimes you're watching is as you apply, be more cautious and maybe pull the skin in such a way where you're not taping their skin into a seam.
What's the worst that happens if that does accidentally happen?
It'll just feel pinchy and get irritated.
Yeah.
It'll feel uncomfortable. And then
And you can't take the tape off and read and.
Yes. Oh yeah.
You can kind of move it a little bit.
Absolutely.
Oh.
Before you really like start rubbing and adhering it, you can take it off and readjust. Once you take it off, you've already started to lose some of it, but that's where if you apply light, you lay it down real light,
So if
and then you can pull it back and readjust.
Gotcha.
Yeah. That ends up becoming part of the mastery of this is just the delicate art of putting tape on skin.
Prepping to make
You
sure it's
just-
clean.
Yeah.
Yeah.
Yeah, and that's one if you'll know you did it, you didn't, because it
Yeah,
just
you'll
won't stay
realize
there
it.
very good. So, all right, break.
Luke, real quick, any advice on elderly, frail skin?
That's part of, yeah. So, part of what I was trying to kind of indicate, but maybe that's more to the point. If we have elderly skin that is both frail and just looser, then I get more cautious with it, and it's a factor in aging that our connective tissues actually do become more and more elastic, like you lose kind of that structural component. So the challenge will be that you have clients coming in that maybe have even been told by their doctor, they've been referred for cupping, referred for taping or connective tissue work, and you are assessing their skin and you're concerned that their skin integrity makes it such that you're worried and usually if the tape isn't put on with a lot of tension, you're really safe. Like this one, for example, the nice thing about splitting the tape into parts, that's not nearly as much of an effect on the skin. So I would feel more comfortable thinking about kind of a quadrupus lymphatic style of taping. Even splitting these in half decreases the amount of the overall force the tape is applying on the skin. So you could decrease it with a lot of caution, verbal caution to the person. But yeah, it's a big question of hey client, if this starts to feel, if you see any redness or anything whatsoever, there would be a case where I suggest keeping it on for only a day or two and then seeing how they respond, and we'll go from there. But yeah, where is caution? Be careful. And the real story there is when the skin is super loose like that, you're gonna have a tougher time getting enough sensory input to the tissue to create this sense of tissue stability. You still would be encouraging fluid movement and connective tissue pliability. So with a client where I'm concerned, I just wouldn't be worrying about crossing joint lines, which that's where the most seams in skin stuff is gonna be anyway. So I just wouldn't do joint stuff as much, if at all. and I would limit how much tension I was putting on the tape as I apply it to certainly less than 50%, if not more around that 20 to 30%. And then see how they respond, and then we can start maybe getting a touch more brave after a few sessions. So, very good question.
I have a quick question.
Yes.
Would you ever use this, say it's someone that is prone to an injury, but they're not currently having a problem, as a preventative, like in an athletic event? Or
Absolutely. That's what you tend to see. And so the sporting stuff that you tend to see is usually coming from two perspectives. Either there's an injury that they're managing. If you see the split stuff like this, and you'll see that with all kinds of basket weave coolness, that's usually managing some kind of inflammatory something. Probably just an angry itis of something, right? Or like what I saw with the football players, and or let's say it's ankle instability, a very common one. The research related to that sensory, that neurosensory integration, or sensory input, is that the sensation of the tape might, these are difficult things to prove, but there is some validating research to show that it may well, for at least some people, give them a bit more sensory input, proprioception, call it, and maybe they'll feel like they have more coordination, that they can just pick up subtler movements, and the best case result would be that either we're talking about movements that would be more refined, even by a tiny bit, and with sports, every step is a stressor on that knee, on that ankle. So if it's even just a little bit more efficient, maybe we decrease the chance of an injury, or we mitigate something that's like mildly chronic. And that was a really common thing for us. Like somebody had a really rough ankle and it's just kind of always just lingering, that this would be a management strategy to make it to where after a game, for example, it's less ornery, or it keeps it from getting more agitated and symptomatic.
So like the one example of what you're saying would be like you got the start and the end point, and you know that you want to focus on that sensation at the start point of the tape. That's your firing spot. That can help turn this gray pain area into more
Yes, yes. And so a little bit in that category where we could think is, I had mentioned the firing pattern stuff, like for the quads, for those of you that have done that one, getting vastus medialis to fire more dominantly related to the other quads is a big thing related to strengthening a knee to its greatest potential. That's the most efficient way the muscles that extend the knee can fire. This one first, this one dominant, then the rest. That's an oversimplification. So I could use the tape sensation as a way to send a signal to that muscle, this tissue, and say to that tissue that, hey, be more aware here. Or I could cross joint lines and try to think more from a proprioceptive balance, coordination kind of standpoint. Both kind of could overlap into the other, but I could think about taping for muscles to function better, or I could tape for joints to maybe function a little bit better. And the argument behind it is that it's not creating stability like a brace, which brackets them in. So athletic taping, where they create a cast around the ankle, which limits how much mobility it has. We're not doing that. We're probably affecting the sensory input of all the tissues around the ankle so that the nervous system's getting a bit more info every time it moves. And then ideally, that extra information makes it do a better job. And that's as good as I can explain it. So, okay. Break, hydrate,